Dear friends and colleagues, it's a great pleasure for me to welcome you to this worldwide online symposium on the Aphrodite criteria for male infertility diagnosis, prognosis, and management. We're going to have some excellent speakers here, and there will be ample time for questions also. With me as co-chair, I have Professor Sandro Este. I think you all know him. He is a reproductive urologist who specializes in treating male infertility, and he's got a specifically connection with ART, which is quite special for a urologist. He's the founder of and medical director of Androphet, and obviously he's also been deeply involved in the Poseidon and now the Aphrodite criteria. Luckily, he's also attached to my university as an honorary professor. So please, Sandro, my co-chair.
Thank you very much, Peter. I would like to welcome everyone to the Aphrodite criteria for male infertility, diagnosis, prognosis, and management virtual workshop. I'd like also to introduce you, my co-chair. Professor Peter Humaydan is a specialist in reproductive endocrinology. He's professor at the Fertility Clinic Skive Regional Hospital, which is associated with the Aarhus University in Denmark, and honorary professor at Odense University in Denmark. Everyone knows Peter. He's an international acclaimed key opinion leader in female infertility and ART, and he also has a special interest in male infertility. Peter also had a critical role in designing the Aphrodite criteria that we'll be discussing today.
Yeah, so we will just proceed now with the introductory slides, Sandro. And again, what is MEDEA? Well, as you can see, MEDEA stands for Medical Education Academy, and it's a global medical education provider and provider of CME. Now, the important thing is that at the heart of MEDEA is an independent and international pool of scientific experts. Sandro, please. And here you see all the therapeutic areas. So actually there are like 5 therapeutic areas which MEDEA takes part in. Now, today we're going to concentrate on male infertility. This is the Female Infertility Scientific Committee. I'm sure you recognize a lot of these highly distinguished colleagues with the scientific director, which is Robert Fisher. But we also in MEDEA have scientific groups of male infertility, AI, reproductive biology, and nursing and midwife.
Thank you very much, Peter. Now I would like to present you some slides about our virtual workshop of today. So, and I'm also very pleased to introduce the group Aphrodite website. This is the official launch of this website, and you'll see more if you want in the web. The Aphrodite board members, actually, they are mostly the co-authors of the paper on Aphrodite that we'll be discussing as well. We are planning to expand this board group, but several of the speakers presenting today are there as board members, as you can see. For today's meeting, besides Peter and myself, we have a panel of distinguished speakers. They will be introduced properly after their talk, but we are having Lynn Antonio from Belgium, Manuela Simoni from Italy, Daniele Santi also from Italy. And in this program, when you go for the website, there's a lot of things you can check. We have included a very interesting podcast about the association of Aphrodite and ancient Greek mythology and infertility. It was a very nice conversation I had the opportunity to have with Nina Papatanasopoulos, who is an expert on ancient Greek mythology. After this meeting, we will upload all the contents for you to check later, and you can watch on demand. And you also have some infographics about the Aphrodite group, so it's quite nice, including the faculty disclosure of these meetings, of all the speakers, as you can see. Well, today's meeting is going to be like 3 hours meeting. We have a busy agenda. in which we divided the program into 2 sessions. Session 1, actually, I'll be coordinating, and session 2, Peter Humaydan. In session 1, we're gonna have 3 lectures. After each lecture, we will have like 10 minutes of questions and answers, and you can use the Q&A that you see on your screen to post questions during the presentations, and we will try to address all questions if possible, and if not, later on we'll post the answers in the Aphrodite website as well. So a second part is going to be more practical approach on Aphrodite, in which you're going to have, let's say, case presentations with discussions, followed by a presentation by Professor Humaydan on ART and male infertility. So after the series of presentations on this session number 2, we are going to have questions and answers, and then we close the meeting. So we hope that you get a valid experience today. Obviously, to design this program, we partner with several societies from different countries, from 4 continents. We had sponsoring societies from the UK, Italy, Spain, Portugal, Brazil, Turkey, Algeria, and Tunisia. All these societies actually supporting us for developing the program. I hope you have already actually answered the pre-webinar survey about your knowledge on, the male infertility aspects that we'll be discussing today. If not, you can check the link that is available on the chat, and then you can do it very quickly. Also, it's very important to let you know that for the accreditation, this program is accredited by the European Accreditation Council for Continuing Medical Education, with 2.5 European CME credits. So you need to fill out the post-event survey that you'll be received by email, actually to receive your certificate. And for this program, we are very lucky to have approximately 700 participants registered from many, many countries, over 70 countries. And as I said before, for the questions and answers, you have, the button on your screen. Just use it to submit your questions, and we will address the questions during the discussion time. So just a reminder, the next Medea activity is going to be on May the 10th. It's another virtual workshop on medically assisted reproduction prediction tools that will be actually presented by several panelists, including Professor Alvigi from Italy, Jerome Chambos, Danilo Simadomo, and Dr. Biliana Todorovic. So with that introduction, we start our workshop with the first presentation that is going to be by Professor Manuela Simoni. So Manuela is well known to all of us. She's professor of endocrinology at the University of Modena and Reggio Emilia in Italy. She's a member of the Aphrodite group and one of the leading authors of the Aphrodite criteria. Professor Simoni's research interests are in gonadotropin and androgen action, testicular function, male infertility, and the endocrinology and pathophysiology of reproduction. She is a member of the European Academy of Andrology and the European Society of Endocrinology, serving as secretary until April 2018. She also serves the editorial boards of several journals in the fields of endocrinology and reproduction, and was past co-editor-in-chief of Andrology Journal, which is the official journal of the European Academy of Andrology and the American Society of Andrology. Welcome, Manuela, to our workshop.
Thank you, Sandro. I hope you can hear me. I have been asked to introduce you the pathophysiology of male reproduction and infertility. So to give you some background on which we have been constructing the Aphrodite criteria. So this is the layout of my presentation. In the next 20 minutes or so, I will give you some information, general information. I think everybody in the audience is familiar with it, about the neuroendocrine control of spermatogenesis. I will show you why gonadotropins are necessary for quantitatively and qualitatively normal spermatogenesis. And then I will introduce an important concept that is spermatogenesis normally does not operate at its maximal rate in the primate. And this means that there is room for hyperstimulation, and this both under normal conditions and in infertility. I will show you how a certain type of hypogonadism can be connected with male infertility. Then there are some interesting data upcoming showing that men seem to become more and more hypogonadal, at least if you look at the evidences of the last 50 years. There is the need of change our attitude as endocrinologists towards male infertility, and we can give some help to the old oocyte or to the aging oocyte as we witness these years by giving the oocyte access to more and better fresh sperm. So if we start with the neuroendocrine control of spermatogenesis, on the left-hand side, you see what you know very well. So the feedback control of spermatogenesis and the control by gonadotropins, two important hormones. The two most important hormones to induce spermatogenesis are FSH and intratesticular testosterone. Testosterone and inhibin B exert a negative feedback at the hypothalamic level. On the right side, you see the fine neuroendocrine control at the hypothalamic pituitary level. We know that the pituitary produces LH and FSH acting on the testes. The testosterone exerts the negative feedback at the arcuate nucleus by acting on the KIS1 neurons. The KIS1 neurons act on the GPR54 receptor to synchronize the GnRH neurons, and the GnRH neurons stimulate in pulses, in spikes, the pituitary to produce LH and FSH. Spermatogenesis is a complex process going from the proliferation of the spermatogonia to the mature sperm takes at least 72 days in the human. This is important because whatever treatment we can try to improve spermatogenesis should last enough to allow enough replication of spermatogonia and the maturation up to the sperm level. So it means that it has to last more than one spermatogenetic cycle. And on the right-hand side, you see that the first steps of spermatogenesis, that is spermatogonial proliferation, meiotic division, up to the first meiotic division, is especially FSH dependent, while the last step is especially testosterone dependent, the maturation, the final maturation of sperm. So both LH and FSH are important. LH because it stimulates intratesticular testosterone to mature the sperm, and FSH to stimulate spermatogonial proliferation. Both gonadotropins are necessary. This is shown by several experiments in mouse. Here you see a number of transgenic mouse models, knockout models, and people have tried to knock out the LH itself, the LH receptor, the androgen receptor overall, or specifically on the Sertoli cells, on the Leydig cells, the FSH beta, and the FSH receptor. What these experiments show altogether is that if you eliminate testosterone action, you interfere with the final maturation of the spermatozoa, and the result is spermatogenic arrest, generally at the spermatid stage. And if you eliminate FSH action, what you have is a reduced proliferation of spermatogonia, reduced testis size, but not necessarily azoospermia, at least this in males, in mice, suggesting that FSH is not completely necessary in the mouse model to have fertility. The situation, however, is somehow different if we are in conditions where the LH action is completely lacking, like in the LH receptor knockout mouse that you see in panel D. If you have an LH receptor knockout mouse, that means that the LH activity is not possible and intratesticular testosterone is very low, then you have a spermatogenic arrest. But if you cross this mouse with another model where the FSH receptor is constitutively active, hyperactivated, and that is panel F, you see that the spermatogenesis is completely restored in the absence of intratesticular testosterone, suggesting that the two hormones are necessary and that FSH can supply a good stimulation in the absence of testosterone. And what the authors of the paper have suggested that a strong FSH action can boost the spermatogenesis beyond that achieved at physiological levels and may even compensate for missing or insufficient testosterone action, like in oligospermia due to partial androgen resistance. So this is an important concept that we can boost the spermatogenesis over the baseline, even in the absence of sufficient intratesticular testosterone. So these are the two important concepts here. Now, what is the evidence for the role of FSH, essential role of FSH, I would say, in spermatogenesis in the human? There are several models suggesting this. First of all, if you have completely inactivating mutations of the FSH beta chain, so no FSH, there are 5 cases reported in the literature, you have azoospermia. In the human, FSH during the puberty stimulates certainly cell and spermatogonia proliferation, especially aspermatogonia. If you do an FSH treatment in adult primates, both men and monkeys, you can increase testicular volume. And I will show you a couple of examples of this. And increasing testicular volumes means that you are acting on the tubular compartment. The model that we have just seen, so if overexpress an activated FSH receptor in an androgen-deprived LH receptor knockout mouse, you support a normal spermatogenesis. And finally, activating FSH receptor mutation in humans in the absence of pituitary sustains the spermatogenesis. And this has been described in 2 cases in men. So it means that the effect of LH and FSH in the human spermatogenesis is complementary and somehow redundant, so that in some cases, if you don't have one of the 2 gonotropies, the other one can take over. The other point is that spermatogenesis does not operate at its maximal level in the primate. There seems to be some kind of, some sort of spare spermatogenesis that can be activated in case of need. And these are some examples of this. For instance, if you perform hemicastration in an experimental model, human or monkey, as you wish, there is a compensatory volume increase of the remaining testes. I will show you an example of this. Men with pituitary secreting adenomas producing FSH have increased testis volume. In trials where FSH has been used to improve spermatogenesis, the testicular volume increases, and the FSH treatment in normal monkeys increases spermatogenesis and testicular volume. Here you see an example of hemicastration. What you see on the left panel is that if you do hemicastration, the other testis increases in volume over time in 5 weeks. On the middle panel, you see that this increase is related to a significant increase in serum FSH levels, which is in turn the consequence of the abrupt decrease in inhibin B, depending on the hemicastration. And on the right panel, you see the demonstration that the increase in the contralateral testis is due to the proliferative activity of B spermatogonia. In trials where FSH was used to improve spermatogenesis in men with idiopathic infertility against placebo, on the left panel, you see that the treatment with FSH was able to increase testicular volume while placebo did not. And on the right-hand panel, you see that the treatment with FSH led to an improvement of DNA condensation, although sperm parameters in this short trial with a small doses of FSH, this did not increase. Another example is FSH secreting pituitary adenomas. Here you see one case of clearly FSH expressing pituitary adenoma. You see the histopathology in the upper right panel, and you see that the testicular volume after removal of the adenoma, this man had quite large testicles, was reduced after removing the chronic FSH stimulation exerted by the FSH secreting pituitary adenoma. Male hypogonadism is related to male infertility, we know that, but what is important to remind here is that especially the cases of secondary hypogonadism and tertiary hypogonadism, where the cause of the problem is at the pituitary or hypothalamic level, where you have low testosterone and especially low intratesticular testosterone, you have, even if your gonadotropins are not increased, they are low or are not decreased, they are inappropriately normal, these are the ideal candidates for gonadotropin treatments, so secondary and tertiary hypogonadism. But are infertile men hypogonadal? This is one paper that we published recently demonstrating that in the men with idiopathic infertility, the blue graph, the testosterone distribution in serum is shifted towards the left compared to normal men with normal spermatogenesis in the lower panel with red color. And if you look at the table, you will see that overall there is a significant decrease in serum testosterone, even if still within the normal range, and a significant decrease in the testosterone LH ratio in these men. So these men are somehow having problems in their spermatogenesis, and simultaneously they have a little bit reduced testosterone, suggesting that there is a reduction in the function of the Leydig cells. So fertile or infertile men have some sort of secondary or tertiary hypogonadism, but what happens in normal men around the world? You all know that since many years, there has been the suggestion in the literature that the sperm concentration is progressively decreasing. And this recent paper of last year, analyzing again the secular trends in the last century and from the beginning of this century, demonstrates that there is an interesting decrease in sperm concentration from 100 million per milliliter in 73 to 49 million per milliliter in 2018. And the steep of the decrease, if you look at the red and blue lines seems to be increasing. So the situation is deteriorating, so that somebody calculated that if it continues like this, there will be 0 spermatozoa in 24 years. I don't think that this will happen so easily, but nevertheless, it is interesting. I was rather skeptical towards these findings of the literature until a few years ago. But then in our group, we did something similar, looking at testosterone temporal trends in the last 50 years. And this is the first time that I show this slide in a public meeting. This is the summary of something like more than 1,500 studies in the literature in the last 50 years, summarizing the levels of testosterone in normal men, so not hypogonadal men, on the left-hand side, and you see clearly a decrease in the last 50 years, a progressive decrease. And this decrease is accompanied by a decrease also in LH serum levels. So these are more than 1 million of people around the globe. This suggests to us that there is a trend towards secondary hypogonadism, even in eugonadal men. And also suggests to us that whatever is the cause of this phenomenon, perhaps also the temporal trend in decrease in spermatozoa is due to an incoming hypogonadal situation depending on a reduction of the pituitary activity in LH secretion. We have to see in the future what is the cause of this. So if we put together all this information, we come to a new concept. So if spermatogenesis depends on FSH and LH, especially intratesticular testosterone, if FSH in excess can increase sperm production over the baseline, which is something very similar to what happens in women, where if you administer FSH, like in controlled ovarian stimulation, you increase the number of dominant follicles. If secondary and tertiary hypogonadism in males can be treated by gonadotropins, if about 1/3 of men with idiopathic infertility have reduced intratesticular testosterone levels, and finally, if there is a generalized trend toward male central hypogonadism, why were we so stupid so far not to think about gonadotropin treatments to increase the sperm output from the testis in infertile men? Actually, in the past, there were a few studies trying to use FSH in male idiopathic infertility, but especially the first studies were quite hesitant in using large doses, because we as endocrinologists are prone to use doses for substitution therapies. If you are hypothyroid, I will give you a substitute therapy with thyroxine. And so we were using substitutive doses in men with idiopathic infertility, which are not men with complete hypogonotropic hypogonadism. But this graph shows that if you look at the dose dependency of FSH treatment, you see that you can increase sperm concentration with FSH treatment if you use doses which are large enough. And this increase in sperm concentration over the baseline, which is possible, as I just showed you, is depending on the dose that you use. So we should be less cautious in our dosage. So I think we can this poses a good basis for the Aphrodite criteria that Sandro will talk about. And so with this concept in mind, we can offer some help for the old oocytes by giving more and better fresh sperm. Why this? Because the age at first pregnancy is increasing progressively in the European Union, but also worldwide. These are just the data of the European Union for any type of conception. The age of women at first trial of ART, assisted reproduction, is increasing as well. and also the age of the man. So the oocytes, this is the data of the German IVF register. You see how it increases now is 35.8. So there is not much we can do with all the oocytes. Because the situation is that if you have a large number of oocytes, like in young age, and a good number of good-looking sperm, then it is no problem. You will have a number of embryos produced, both in a natural conception or after ART, and the probability of pregnancy is very high. But if you have old, few, and sick oocytes, and you, on the male side, you have few and bad-looking sperm, then the probability of obtaining good-looking embryos is very small, and you don't have any pregnancy. Now we have to, if we cannot act on the few and sick eggs, then we can try to help the sperm, the male side. Because if you have a few sperm and good oocytes, like in a young woman, then we all know that pregnancy is still possible. Maybe if you do assisted reproduction with less embryos, but it is possible. So it should be possible as well to counteract the old oocytes or give some help to the old oocytes and sick oocytes, but by improving the number and the quality of sperm and obtain a pregnancy. So in conclusion, we think it is time for a paradigm change in the treatment of male infertility, and this is something that we have extensively treated in a recent paper. I think we have to move away from the cautious substitutive treatment of hypogonadotropic hypogonadism by using larger doses of FSH in infertile men, because they have a quantitative or qualitative problem in spermatogenesis, which can benefit from an extra stimulus, because we can push spermatogenesis above the baseline independently from the etiology. And this is the basis for the Aphrodite criteria. So we have to go from a substitutive to a pharmacological FSH stimulation, trying to boost the spermatogenesis over the baseline, and this both for natural and ART pregnancy. And thank you very much for your attention.
Thank you very much, Manuela. I think it was an excellent start. So I would like to thank everyone who is attending online. We have approximately 300 people actually with us, so from different parts of the world. So thank you very much. You can start posting your questions in the Q&A box. This session is open for questions, and I would like to start. I would like to start by commenting, Manuela. This is very interesting, the concept of, let's say, hyperstimulation in the male. But considering the half-life of FSH when we give it subcutaneously in particular, how do you think we should best apply, the FSH stimulation? Is there any ceiling level of FSH, or, I mean, how we can actually think in terms of the pathophysiology that you described us and apply in clinical practice for clinicians?
We could just start applying the same scheme used for assisted reproduction, where you try to do controlled ovarian stimulation. Usually we start with 150 units every day, and let's see what happens. There is no, differently from women, in men, there is no danger of overstimulation. So there is the potential to go even higher. The point is that we have to do it for long enough, because, as I mentioned, spermatogenesis takes time. And so we have to allow time to the spermatogonia to proliferate and to mature. So I don't see any problem with ceiling effect. I don't see any problem with hyperstimulation. I would give, considering the half-life of FSH, one shot every day and not every other day, exactly like you do in women, but just for longer time.
But Manuela, did you do this yourself every day? Because as far as I remember, you were doing it every second day, or did you change your policy?
I think Daniele can answer this question better than me.
Yeah.
We are somehow changing, but we are, in Italy we can prescribe FSH for male infertility, and this is according to the national health system. But the official scheme, which is allowed, is one injection every other day, so 3 times a week.
And Manuela, just another quick question. An extremely interesting study which DeSanti was now submitting, the correlation between reduction in LH and testosterone, and you went over very quick. Could you hypothesize what's going on? Why?
That's an interesting question. Probably what we measure LH in periphery is just a proxy of what is going on in the testes. Probably the Leydig cell is dysfunctional. We are measuring testosterone because this is the only thing we can measure, and we are measuring in the periphery and not intratesticular. But let's think that I think that in some men, at least they are very heterogeneous, those who have a tendentially reduced testosterone are telling us there is a dysfunction of the Leydig cells within the testes. It doesn't have to be testosterone because testosterone is still in the normal range, but this is what we can measure.
Thank you.
Well, we have some questions I would like to from the audience that I would like to share with you. So the first one, I think you already answered about the dosage and how long. There's another question by Professor Cole from Israel. He's asking about aromatase inhibitors, if there's any way that they can replace, the FSH, and then along these lines, because FSH stimulation might be expensive treatment. So, is this something that, if you please comment?
Yes, there are data in the literature about aromatase inhibitors and SERMs. Actually, this is a cheaper way to apply the same concept. It goes via the hypothalamus in this case. But the point is that you want to increase the endogenous gonadotropins. Of course, this is another approach. I am not aware of serious studies with these drugs. The point with aromatase inhibitors is that you increase, one point could be that you decrease estrogens everywhere, also in the bones. You know that estrogens are important for bone health, also in the males. So we have to see what happens in the long run, if they have no side effects, because the treatment must be continued for a long period. But in principle, yes, they could be a cheaper version of producing an increase in endogenous gonadotropins, both of them, LH and FSH.
Manuela, I was told also that in some males, actually, you will have a significant reduction in libido because you need estradiol also around for libido. So I think this is a real problem. And someone was telling me it was up 20% of males.
Yeah,
so
this is another point. Thank you. I have forgotten to say that. And this is particularly important. You have to continue the treatment for a long time.
So Manuela, in terms of the polymorphisms, not because you mentioned the mutations in your presentation, but now thinking about the variants affecting FSH and the FSH receptors in terms of these polymorphisms, perhaps LH. Do we need to, consider that? Because obviously, if you are using like aromatase inhibitors or selective estrogen receptor modulators, we are increasing the endogenous production. And then if the patient has the polymorphisms, how actually it's complicating the situation. And in that case, I believe that the exogenous FSH would be much better. What's your opinion?
For sure, if you use only exogenous FSH, you don't run into the danger of increasing testosterone too much, because you know that testosterone can be even too much. So you can produce polycythemia, you can produce problems at the prostate level, at the hematocrit, and so on. So for sure, if you use only FSH, you don't have the problem of increasing testosterone too much. The point of the polymorphisms, I don't think there is enough evidence about the LH receptor polymorphism that they can play a role. There is some evidence about the FSH receptor polymorphism that they can respond better or worse to the FSH, endogenous or exogenous, doesn't matter. But, you know, by definition, these are polymorphisms. So they are not pathological situation. I don't expect non-response or either excessive response. Neither nor. So I would not make polymorphism analysis before starting treatment. In case that you have some men who are lower responders, it can be useful to analyze polymorphism.
So
and
perhaps
increase the doses, for instance. Okay.
Thank you, Manuela. Manuela, I think we have time for last question from the panelists. And there's one question by Professor Halak. He's from the University of São Paulo here in Brazil, asking about measurement of intratesticular testosterone. If you could comment on this part as well.
You mean measuring intratesticular testosterone in infertile men?
Or in general, how we do that? And
No,
is there
we don't.
any other surrogate measure that we can use?
No, I don't think it is possible to measure intratesticular testosterone unless you do anyhow a testicular biopsy and even fine needle aspiration. But I don't think it is of any useful because intratesticular testosterone is very high anyhow. So especially in idiopathic infertility, I do not expect a decrease in intratesticular testosterone of an entity to justify hypospermatogenesis. We know that intratesticular testosterone can be very low only when you really put the gonadotropins to zero. So you abolish completely pituitary function. This has been shown in contraceptive trials where pituitary gonadotropins have been completely depleted by GnRH antagonist. Even there, intratesticular testosterone is still very well measurable. So it is at this stage not possible to correlate intratesticular testosterone with any sort of reduced spermatogenesis in infertility.
So thank you very much, Manuela, for discussing these points and the presentation. Now it's back to you, Peter.
Thanks a lot, Manuela. It was an extremely nice lecture and very instructive for all of us. Now, the next step is for Sandro Estates to introduce you to the Aphrodite criteria. Why did we come up with this? And also the classification of the 5 groups. There we are. Good.
Thanks a lot. So this is a new approach to classify men with infertility who could benefit from hormonal therapy. And I'm a firm believer that upgrading how we classify male patients can lead to better management and outcomes. So let's dive in. So Aphrodite actually is the acronym for addressing male patients with hypogonadism and or infertility owing to altered idiopathic testicular function. Well, actually, this is a long sentence, but we wanted to take letters to make our Aphrodite as the acronym for our classification. And the reason is that Aphrodite in ancient Greek mythology was a female goddess of fertility, male sexuality, and procreation. So she's the female counterpart of Poseidon, who was a male god for women's fertility. And Poseidon is actually the acronym we chose several years ago for our classification system for low prognosis women undergoing assisted reproductive technology. So we had Poseidon for female patients, and we need Aphrodite for male patients, because until now, limited progress has been achieved in the management of men with reduced fertility and reduced spermatogenesis. So the Aphrodite actually criteria were crafted through a collaboration of experts inspired by the Poseidon concept. Besides myself, we had from Denmark, Professor Humaydan, Professor Johansen. We had from Italy, Filippo Baldi, Manuela, who presented her talk a few minutes ago, Daniele Santi, and also Carlo Alvigi. From the UK, Professor Barrett, and also Alan Pacey. From Germany, we had Herman Berry, and from Belgium, Lynn Antonio, who is going to present as well during this workshop. So, well, our aim was to address a persistent challenge, which is the limited progress in the clinical management of men with reduced fertility and reduced spermatogenesis. This is a stagnant scenario, which is frustrating for clinicians, for the patients. So this group of experts believes that the new criteria can provide a system to identify and characterize infertility in men seeking paternity and who are also potential candidates for gonadotropin treatment. But it's worth noting that these criteria are not applicable to men already diagnosed with infertility due to conditions like varicocele, infection, obstruction, because these patients would not typically benefit from hormonal treatment. So during Manuela's talk, we got a fascinating insight into the biology of spermatogenesis, the pathophysiology of male infertility and hypogonadism. Now I want to highlight some of the crucial aspects that Manuela presented that are essential to grasp the Aphrodite criteria that I will present the groups in a moment. So to start with, it's important to remember that spermatogenesis is quite an intricate journey, spanning for about 75 days, and it's mainly orchestrated by FSH and LH-driven testosterone. So as you are well aware, the hypothalamus kicks things off by releasing GnRH, which triggers the pituitary gland to release FSH and LH. So within the testicles, it's all about the Sertoli enlightened cells, crucial players in responding to these gonadotropins. So LH is crucial in spermatogenesis because it promotes testosterone synthesis in Leydig cells. So once produced, testosterone finds its way to reach the Sertoli cells, where it binds to androgen receptors. This interaction fine-tunes gene transcription and also prompts the secretion of paracrine signals essential for the spermatogenesis process. So in terms of testosterone, please remember that the primary function of testosterone is to promote development of round spermatids into mature sperm during spermiogenesis, which represents the late stage of the spermatogenesis process. Additionally, testosterone also helps transition type A to type B spermatogonia, and it upregulates androgen receptor expression, giving Sertoli cells a boost in their performance. So FSH acts synergistically with testosterone. This is a very important molecule. And like testosterone, it's going to act on the Sertoli cells, offering metabolic and structural support for spermatogenesis. But it's not just a one-trick pony either, because FSH also helps regulate spermatogonial proliferation. So although it might not be the start of the show for spermatogenesis completion, because testosterone is important for that part, its deficiency markedly reduces, the sperm output. So what happens to our male patients then is that the Leydig and Sertoli cells might miss out on the right signals if there are deficits in the production or action of FSH and or LH. So as a result, spermatogenesis might be adversely impacted. So in men with hypogonadism, for example, that Manuela explained, Leydig cells may not be able to secrete enough testosterone, even if circulating LH levels are good. So hypogonadism is common. Manuela presents data about 25–30% of patients with hypogonadism. Later on, I will present some data on patients with non-obstructive vasospasmia, but hypogonadism can arise from various conditions, ranging from internal testicular issues, systemic diseases, infections, genetic abnormalities, aging, and even obesity. But sometimes the culprit remains a mystery, leading to what we call idiopathic hypogonadism. This deep dive into biology has been crucial, actually, in shaping the Aphrodite criteria, which have simple key objectives relevant to our male patients. The first objective would be to enhance semen quantity and quality for those patients aiming for natural conception, and also increasing semen quantity and quality to help make the ART treatment more successful. So the classification of male infertility using the Aphrodite criteria is based on clinical patient descriptions that can be obtained from medical history and physical examination, and also routine lab tests, including the basic semen analysis, FSH levels, and total testosterone levels. Well, now I will present information about the lab tests, starting with the semen analysis. For the Aphrodite criteria, we must apply the WHO framework and reference ranges. So patients are classified as having normal or altered semen analysis parameters using the 50th percentile of the WHO reference ranges. This is that you can see in the slides are the 2021 reference ranges for the WHO manual for the semen analysis, and also includes azoospermic patients in the classification. So for FSH levels, patients are grouped as low, normal, or high based on typical reference ranges. I mean, the platforms, these values may vary according to the platform used for FSH measurement. So you can actually look into your own, laboratory, providing the information for you. But obviously, if we are designing a trial to, explore interventions, we need to properly define the ranges that we are actually addressing. But for the clinical practice, I think most of us use the chemiluminescence immunoassay platforms. And here you see some of them with the reference ranges provided by FSH that we can discuss later on. So when it comes to testosterone levels, we categorize patients as either normal or reduced, hypogonadal, relying on the cutoff values outlined in most pertinent guidelines. One particular critical threshold that has been set is 350 nanograms per deciliter, which is equivalent to 12 nanomoles per liter. This seems to serve as the most consensual threshold for identifying patients with biochemical hypogonadism, as you can see, issued by most societies, specifically the European Academy of Andrology, European Association of Urology, and so on. We have these thresholds actually, but we have also lower thresholds by other societies. But it's important to remember that lower thresholds have been including patients with older age who do not actually represent the population we treat in terms of reproductive, our reproductive patients. Well, using these results and the clinical patient descriptions, we have then eligible patients, patients who might be candidates for hormonal therapy. They will be stratified into one of the 5 different groups, and suggestions for unified clinical management using gonadotropin are provided. So these patients are fully characterized, including suggested, therapeutical management and relevant endpoints, Here you can see Aphrodite group 1. We are looking at patients in Aphrodite group 1 who have congenital or acquired hypogonadotropic hypogonadism. So in simple terms, these patients have a severe hormonal disorder caused by deficient gonadotropin production or action, which will prevent their testicles from producing enough sperm and testosterone. So when we see these patients in clinical practice, they typically exhibit low levels of FSH, LH, and testosterone, as well as azoospermia, less frequently severe oligospermia. But here's the silver lining. Gonadotropin replacement therapy using HCG and FSH can work wonders for up to 90% of men in Aphrodite group 1, reviving spermatogenesis. So with the right treatment, these patients stand excellent chances of becoming fathers. So moving on to Aphrodite group 2, here we see that we are talking about patients mostly with idiopathic oligospermia and also some specific case of non-obstructive azoospermia. So these patients, they have abnormal semen parameters that could be as extreme as azoospermia, but FSH and testosterone levels within the normal range. Just to refresh, just remember that patients with idiopathic male infertility have abnormal semen parameters, but they lack a history of diseases affecting fertility, and additionally, their physical examination and lab results are unremarkable. These patients are believed to have functional hypogonadism caused by reduced gonadotropin action, even though their serum levels seem normal. So we have research suggesting that FSH therapy could be a game changer, enhancing semen parameters and boosting pregnancy rates in men with idiopathic oligospermia. And similarly, this approach of gonadotropin therapy may hold promise for selected case of non-obstructive azoospermia. Well, Aphrodite group 3 is actually a variation of group 2, but here patients showcase abnormal semen analysis parameters, normal FSH levels like group 2. The difference relies on that in this group, the patients have reduced testosterone levels, indicating biochemical hypogonadism. So in this scenario, we speculate that co-administration of HCG and FSH may offer additional benefits. So given the fact that HCG has potent LH activity, it boosts intratesticular testosterone production and might help stimulate spermatogenesis. So we have some data suggesting that gonadotropin therapy can improve sperm quantity in patients with idiopathic oligospermia and sperm retrieval rates in patients with non-obstructive azoospermia who fall into Aphrodite group 3. So moving on to Aphrodite group 4, this category primarily includes patients with non-obstructive azoospermia. They display elevated FSH levels and reduced testosterone levels, mostly indicating hypergonadotropic hypogonadism. Well, these patients have a very low testicular reserve, making them the most difficult patients to treat. Like, for example, we have in Poseidon group 4 patients, women with very low ovarian reserve. But despite the challenges in treating these patients, there are some observational studies and case series indicating that mainly employing HCG, there's a ray of hope because sperm retrieval rates can be potentially increased after, gonadotropin therapy in selected patients with, non-obstructive azoospermia in this group. Now, wrapping up with Aphrodite group 5, this group comprises patients with unexplained infertility. Taking a closer look from the male perspective, let's recall that patients with unexplained infertility, they have semen analysis parameters within the normal range, no history of diseases affecting fertility, and normal physical and laboratory findings as well. Now, As Manuela stressed during her presentation, the notion of employing FSH to stimulate spermatogenesis in this group is based on the fact that in primates, spermatogenesis does not run at its maximum capacity, and extra FSH may be able to stimulate spermatogenesis beyond its baseline. Obviously, we need further research to validate these findings in humans. So we have then, the 5 different groups. We know that while gonadotropin therapy seems effective in treating Aphrodite groups 1, 2, and 3, we have a lot of data in group 1 in particular, and we have some data in groups 2 and 3. The clinical feasibility of gonadotropin therapy in the remaining groups, groups 4 and 5, needs further validation. So in the next talk by Dr. Santi, he's going to focus on delving deeper into the effectiveness of gonadotropin therapy. So in a nutshell, the Aphrodite criteria presents a finely tuned patient stratification that we believe can facilitate communication among all stakeholders. We believe this is an innovative method with the potential to streamline patient care and identify specific groups for targeted interventions, offering practical benefits for clinicians and researchers. By applying this system, we can also shed some light on the prevalence of various patient groups, and we can also compare between treatments and outcomes. And beyond that, Aphrodite could serve as a springboard for uncovering new pharmacological interventions, and through meticulous analysis of patient groups, we can even eventually discover new causes of male infertility, particularly concerning genetic aspects of male infertility in patients previously categorized as, having idiopathic oligospermia. We are very excited about the possibilities that this approach holds for the future, not only for practice, but also for research. So I want to extend a warm invitation to all of you to read the Aphrodite paper in detail. It's readily accessible as an open access publication in this month's issue of Reproductive Biomedicine Online. So happy reading, and let's explore the exciting field of male infertility together. Thank you very much for staying with me.
Thank you very much, Sandro. I think you should just also mention the In a Nutshell, Aphrodite in a Nutshell paper, which you and I published very recently in the Brazilian journal, which is quite comprehensive and let's say, a summary of the whole Aphrodite. Now, there are quite a few questions. Now, one question which I think is interesting from the audience is, the question is, in idiopathic males, so this is now, we're talking about Aphrodite group 2, does FSH stimulation improve sperm parameters enough to make a meaningful change to treatment? So, converting oligospermia male to normal parameters, this is the question.
Yeah, I think this is the question that, will be answered during Daniele's presentation. We have some studies indicating that actually we can improve these parameters. Some patients, obviously, it depends on the baseline. Obviously, if we have, let's say, patients with extremely lower levels, patients might not actually respond properly. But we should not think only in terms of the count, concentration. I think we should also think in terms of quality. And there's, good evidence suggesting that FSH stimulation can decrease sperm DNA fragmentation. And also, we know that FSH has anti-apoptotic properties that could help to improve the quality of sperm chromatin. And this could be also an important factor to consider, given the importance of, the sperm chromatin for producing healthy offspring, Peter. So I think we need to think more holistically in terms of not only the count, but also the quality. Even if we still need to apply ART, we could actually improve the outcomes by considering gonadotropin therapy in selected patients.
exactly. Actually, this was one of the questions. So, Sandro, can you just give us an estimate of how much the reduction in FSH in DNA fragmentation index is in the studies that we saw until now after FSH treatment? Have you got an estimate of this in percentage?
In absolute values, there is about 4 to 5 million million sperm per ml increase in the randomized control trials looking at FSH therapy. And in terms of absolute values of DNA fragmentation, it's around 20-25% relative decrease in sperm DNA fragmentation.
Yeah, okay, thank you very much. So there are a lot of questions, and I think these questions actually will belong to the next speakers, because it's more or less like, how long do we treat with FSH, in which doses, etc., etc. And Danielle is going to cover this. So I think we will jump upwards. What I would just like to ask you is, what do you think the characteristics of the idiopathic male infertility group is? Because here everything seems to be normal, but still the spermatogenesis is running low. And I know that Manuela alluded to this also, but what do you think the physiological rationale for this could be? Could this be something with the gonadotrophins, the intrinsic gonadotrophins, or what?
I think could also be related to some variants, some polymorphisms affecting, the transcription activity of FSH relies on a single SNP. So, I mean, if we have a problem, I mean, in a variant, a polymorphism is affecting the FSH beta gene, for example, we can have a molecule not actually working properly. We can also have problems affecting the FSH receptors. So when we kind of measure FSH, testosterone levels in the peripheric blood, we are having a snapshot of the immunoassay actually providing these results, but we are not actually measuring the effect of these molecules at the testicular level. And we have what we call, at least we hypothesize this functional hypogonadism. So yeah, this is another important issue. So patients might have the polymorphisms, variants, and this is why actually we put as idiopathic. We are not checking pharmacogenomically routinely, and so these patients might have this condition of lack of proper action of the gonadotropin, either the molecule or at the receptor level.
Okay, so there's a question also about group 4, but you're going to go into this. The question is, when do we use HCG only, and when should we add FSH? But you're going to show this in a case, I'm sure. Shahakul asks, does this mean that LH measurement in male is redundant? So we should focus on testosterone and not LH?
I think this is an excellent question. I think, for instance, for Aphrodite, we try to make the classification very simple using parameters that we all have. But obviously, every single reproductive urologist and andrology, when actually evaluating a patient with male infertility, we order, Peter, the full panel. We have data on testosterone, LH, prolactin. We have thyroid hormones as well, because obviously when we think that the patient, when you say, well, this patient have biochemical hypogonadism, testosterone levels are low, we need to rule out certain conditions like hyperprolactinemia, thyroid disease that could affect, also the measurement of testosterone in the peripheric blood. This is important. But for the classification per se, I don't think we need to look into LH. Obviously, if I prescribe an intervention for my patient and the LH levels are very high, my expectation as a response to therapy would be, less, because I know that this patient has lower Leydig cell reserve. So for, prognostic purpose or for designing studies, I believe LH could be, looked into as a modulatory factor, predictive factor for the therapeutic response. The same as estradiol levels. We can also say, okay, perhaps having estradiol levels might help us to best select patients suitable, for example, for aromatase inhibitors to start. But for the classification per se, I think we all agreed during our, meetings discussing Aphrodite that should be simple. And then obviously the extra information like LH measurement and estradiol measurement and even BMI can be part of, the way we monitor the results of intervention. Just for you to know very quickly, we looked into our data. We have a large database of patients with non-obstructive vasospasm. So looking into our data, and when we talk about group 3, patients with non-obstructive vasospasm falling into group 3, so they have FSH levels within the normal limits, and we have low testosterone levels. Only 10% of our patient population had high LH levels. So it's very low. So the percentage of patients with high LH levels in group 4 in our database of non-obstructive vasospasmic patients increased to 38%. So obviously, these are the patients with very low testicular reserve. So in terms of LH, I think it's a bit redundant, and could be used as prognostic factor for treatment.
And then just the last question from the audience. Obviously, I'm sure you can answer this very quickly, because someone asks here, do you consider there would be any risks from FSH treatment for the offspring?
Well, we don't have data on that. We have the randomized control trials that goes up to sperm quality, sperm numbers, and also pregnancy results in terms of clinical pregnancy and live birth, but we don't have actually, information about offspring. From the practical perspective, we have a lot of data at our center about patients with non-obstructive vasospasm using gonadotropin therapy before sperm retrieval. And then we have offspring, health information, and we don't see, in our hands, any particular relevant, increase in any, health issues for the offspring. But obviously, this is just a single-center experience.
Well, Sandro, I would think, we have now more than 8 million IVF children born by FSH stimulation of the women. So I would be very, very surprised to know that the FSH stimulation of the male would have a negative impact on the health of child. This is just my subjective meaning. But thank you very much, and I'll now leave it for you to introduce the next speaker.
So, yeah, thank you very much, Peter. Now it's my great pleasure to introduce Professor Daniele Santi. Daniele is assistant professor at the Unity of Endocrinology of the Department of Biomedical, Metabolic, and Neurosciences of Unimore, which is the University of Modena and Reggio Emilia in Italy. He works in close collaboration with Manuela. Daniele had a critical role designing the Aphrodite criteria. He has published extensively in the field of andrology and male infertility with some seminal contributions, actually, in these fields. Daniele serves as associate editor of Andrology Journal, Frontiers in Endocrinology and Reproductive Medicine Journal, as he is also section editor for Andrology in a new journal named Reproductive Female and Child Health. So with that, welcome Daniele for our virtual workshop. The floor is all yours.
Thank you, Sandro. Okay, so I thank you for the presentation for the first. Okay. So my task is to give an overview about the application of gonadotropins in the clinical practice, in the management of male infertility. And I just want to start with this slide, because we have first to diagnose the reason of the male infertility, because the first step that we have to do in clinical practice is to recognize the cause and to treat the cause of the male infertility. And here is the question of when or where we can use gonadotropions in clinical practice. And so here is where the Aphrodite criteria that Sandro explained us could enter in clinical practice, where we can select the patient, classify the patient to select which should be the best approach in terms of also of gonadotropins. And in order to start the overview, obviously, the first group, the group 1 of hypo-hypo, is the best example in which gonadotropins could be used in clinical practice. And I don't have to explain which is the definition of hypo-hypo, but for sure we have to start thinking about the reason of the infertility in these patients, and in particular considering the classical hypo-hypo, so patients in which we have the lack of the physiological stimulation between the pituitary gland and the testis. So when the gonadotropins are not produced or lower, and this is the setting in which we can effectively do something of efficient from a clinical point of view. So we have to replace the normal stimulation of the spermatogenesis. And for this reason, we have to remember the physiological regulation of spermatogenesis that, as also Manuela Simoni already explained us, spermatogenesis required a complex and synergic stimulation of FSH from one side that is required in the first steps of spermatogenesis, but also testosterone, intratesticular testosterone, that it derives from the activity of DLH on the Leydig cell. And this is what we have to replace to treat this patient for the infertility. Many trials already try to evaluate the efficacy of gonadotropin stimulation, or better, the replacement therapy in patients with hypo-hypo, and generally azoospermia, so a severe alteration in semen analysis. This is the most comprehensive meta-analysis published and available in the literature. It was published 10 years ago. In this work, the author searched the literature for those trials in which men with hypo-hypo and azoospermia were treated for infertility. They detected 44 studies, as you can see, in which they were treated with gonadotropins. These studies are heterogeneous, for sure, in terms of characteristics of men enrolled and treated. So we have prepubertal hypo-hypo, also post-pubertal hypo-hypo, and from a clinical point of view, for sure, these patients are different. But also the treatment is not so homogeneous, since we have studies in which ACG was used alone, other in which FSH was used added to ACG, and again other in which FSH was added later after ACG stimulation. In terms of efficacy, this is the comprehensive results, and you could see by the first plot that on the left, the sperm concentration significantly increased after gonadotropin stimulation. You could see that the author performed a subgroup analysis according to the type of FSH, so urinary derived, recombinant, and also using FSH plus ACG that still represent the gold standard approach, or ACG alone. Overall, there is a significant increase in sperm concentration, but if we look at the subgroup of only ACG treatment, you could see that the significant increase is very, very slight, probably not so clinically efficient. On the right, the second forest plot shows the number of patients that achieve at least one sperm in the ejaculate. And you could see that there is a significant number of men that after treatment increase and appear at least one sperm. And this is for sure a very important result from a clinical point of view. And this translates in a significant number of pregnancies. Obviously, the pregnancy is the strong outcome in these trials for sure, but also in clinical practice. And in this table, the author reported that the number of pregnancy achieved during the study, during each study. You could see that not all patients, or the column total number, there is also the number wishing pregnancy. So not all patients enrolled wishing a pregnancy, but the number is very, very important and impacting, since this treatment is efficient. And we know that this approach, so the replacement approach of gonadotropins in hypo-hypo, is clinically significant, increasing and improving semen quality, sperm number, and also pregnancy. However, we still have many questions still open in the setting, because first of all, we don't have any predictive factors so far that could predict the real efficacy of this treatment in terms of pregnancy. As well as we don't know which should be the best regimen or the time required for the stimulation. And I thought that the standard approach provides the complex and synergic stimulation of FSH and ACG, but we don't know really which should be the best duration, dosages, and so on. And overall, I think that the most important question remains the selection of the gonadotropins, because you know that if we have to replace the gonadotropin stimulation of the spermatogenesis, we have to consider both the stimulation and, for example, if we want to stimulate intratesticular testosterone production, which should be the best option. In this setting, you know that we have two molecules, so LH that physiologically act on the LHCG receptor, and also ACG that act on the same receptor. And you know that from a pharmacological point of view, ACG is the most used, since the ACG act on the same receptor, stimulate the same pathway, at least this is what we thought. And this is used generally in clinical practice. However, we know that LH and ACG are really different, at least from a molecular point of view, biochemically, since they act on the same receptor, this is true, but they activate different signal transduction pathways. And there are many evidences in the literature that confirm that ACG is more active in the stimulation of steroidogenesis, whereas LH stimulates steroidogenesis, but also other pathways involved in cell survival, cell proliferation. So the action is different from a molecular point of view. We have also evidences in women that from a clinical point of view, LH and ACG could have a different role also in humans, and not only in at molecular level. However, in the men, we don't know if LH and ACG are really different from a clinical point of view, since no studies so far evaluated the potential differences between these two molecules, these two gonadotropins. And so this is the reason why we are conducting, I think it is relevant to show today. This is a study, a multi-center study that we are conducting in our center with the other center in Italy, with the aim to compare the pharmacodynamics of LH and ACG in men with hypo-hypo. So in this man that we can classify in the group 1 of Aphrodite criteria. And so this is the study design. So we have two different groups. The study groups in which men were treated with recombinant LH, and the control group in which ACG is used. You could see that the study lasted 2 months of treatment and again 1 month of treatment withdrawal. And you could see an increasing dosages of LH in the study group and of ACG in control group. This is very important also for ACG use in hypo-hypo, because nowadays what we do in clinical practice in front of hypo-hypo man is to use ACG generally at the dosages of 1,000 2 times weekly or 2,000 2 times weekly, but we don't have any evidences that this is the real dosages needed to stimulate the testis. And I just want to show the preliminary result because it's very interesting. We have up to now enrolled 12 patients and 8 have completed the treatment and also the follow-up phase. 6 were enrolled in the study group by randomization and 2 in the control group. And this is the result just of the testosterone serum total testosterone serum levels. You could see that there is in the y-axis the testosterone, in the x-axis the number of the visits. And you could see that in the control group, and so the blue bar, that there is a significant increase in testosterone serum levels that reach a sort of plateau after 1 month of treatment. But otherwise, the equal dosages of LH used in the study group did not lead to a significant increase in testosterone serum levels, suggesting that and confirming at least that the differences between LH and ACG detected at molecular level seems to be real and evident also in men in clinical practice. Obviously, the study is still ongoing, and so this is just preliminary result, but very interesting to understand the differences. Then we have also to consider, even in hypo-hypo, the FSH stimulation. You know that from FSH we have many different compounds from the urinary derived until the most recent recombinant, and generally in this man treatment is of 150 units every other day to replace the physiological stimulation. Although also for FSH, we don't know the real dose needed to replace the physiological stimulation. So the application of gonadotropins in the group 1 is very clear, although many questions remain open. But the real challenge in clinical practice is the use in the large group called idiopathic infertility. So those men in which we have an alteration in semen analysis, but we don't have any reason, at least we don't know the reason of the alteration. And so this could represent at least the group 2 and 3, at least, of the Aphrodite criteria. In this man in clinical practice, these are the options that the guidelines, this is the table available in the European Academy of Andrology guideline in the management of male idiopathic infertility. We have 3 options, but so antioxidant, FSH, and anti-estrogens. But you will see that for all these 3 potential treatment, we have a grade of recommendation very low, so just a suggestion, and the level of evidence is not so high. However, looking at the comments, you could see that the author are not able to suggest in favor of the use of antioxidants and anti-estrogens, considering the available literature at least, but they could at least suggest the use of FSH, considering the literature, in selected patients with infertility, with idiopathic infertility. And this is also what we have, we could find also in the Italian Society of Andrology and Sexual Medicine guideline in the management of male idiopathic infertility. And you could see that also our national society suggested the treatment of FSH in selected patients. the evidence of the efficacy of this approach is available in the literature. We have more than 20 trials that try to demonstrate the efficacy of the role of FSH administration in idiopathic infertility. This is the last meta-analysis that tried to put together this result and showing that giving FSH, we have a significant increase in both sperm concentration and total sperm number after stimulation. The author also combined the result from the literature according to the dosages of FSH used. And you could see by the first plot that using a low dose, we don't have a significant increase in sperm concentration at the top. And but we have an increase using an intermediate dose, that is what is doing in clinical practice. But also we have a significant higher increase in sperm concentration using high dosages of FSH. So suggesting that probably we have to think about this treatment. Moreover, we have also some studies that demonstrate also significant improvement in sperm quality after FSH administration. This meta-analysis evaluated the sperm DNA fragmentation index. You know that this is a second-level examination that gives us relevant information about the competence and the quality of the sperm. The higher is the sperm DNA fragmentation, the lower is the competence and the quality of the sperm. And putting together the evidences, we can conclude that giving FSH, we increase the quality of sperm detected by a reduction in sperm DNA fragmentation index of about 4%. And finally, considering the strong outcome, so the pregnancy, the evidence in the literature suggests that giving FSH, we increase the pregnancy, both spontaneous pregnancy, but also pregnancy after assisted reproduction, as you could see in the two first plots. Using this data to calculate the number needed to treat, however, the number is not so good. I mean, we detected that we need to treat from 10 to 18 men to obtain one pregnancy. Obviously, this is not a strong result from a clinical point of view, but probably we have to rethink the approach, since we have some evidences suggesting that FSH, increasing the dosages of FSH, we increase the response. Probably we have to rethink and to change from a replacement therapy to a stimulated approach, as also demonstrated before by Manuela Simone. And finally, I just want to show the result of what happened in clinical practice, because in Italy, FSH could be used in the management of male idiopathic infertility. We have a national rule that allows us to give FSH in men with idiopathic infertility with FSH normal. And for normality, the threshold of 8 units per liter is defined by the national rule. In this study, we analyzed the data about 156 men with idiopathic infertility treated with FSH, and we evaluate before and after the treatment. We observe a significant improvement in terms of sperm quality and quantity. In particular, we have an increase in patients with normal semen analysis after treatment, and also a reduction in number of patients with azoospermia. And moreover, we collected 43 pregnancies in our group, suggesting that 1 man every 4 men treated obtained a pregnancy. Obviously, this is not a control study, so this is not a number need to treat, but just a snapshot of what happened in clinical practice in the use of FSH that could also be improved. We know, but this is a good starting point. So to conclude, I think that the Aphrodite criteria should help us to better select the patient and probably to personalize the treatment. the use of gonadotropins in hypo is efficient, but also in this setting, we have probably to improve our knowledge and try to answer several questions that we still have to in mind, such as in particular the best gonadotropins to be used. And again, also in male idiopathic infertility, that is a wide group, the use of gonadotropins show a good potential. Probably also in this setting, we have to better understand and increase our knowledge. So thank you for your attention.
Thank you very much, Dani, for the excellent presentation. I see, I mean, a lot of comments here, a lot of questions for you. So let's try to, address some of them. I would like to start by asking you your questions related to, we are talking a lot about gonadotropins, but people were asking about other, options like aromatase inhibitors, selective estrogen receptor modulators. Obviously for Aphrodite group 1, we cannot use these drugs because they will never work, given the lack of, pituitary secretion of FSH and LH. But I think now the question is more related to, groups 2 and 3. Do you see how actually you react to this question?
Yeah, the use of aromatase inhibitor, selective estrogen modulator is an option from a physiological point of view in idiopathic infertility, since they increase the physiological production of gonadotropins. So we know that also in some countries worldwide, these are the option used. And for example, FSH or gonadotropins are not used for idiopathic infertility, for example. However, I think that if we rethink the approach of male idiopathic infertility, changing from a replacement therapy to a stimulatory approach, so in which we have to increase the stimulation, the use of these drugs is not so helpful, because with this approach, we are not able to increase so much the gonadotropin production physiologically, and so the stimulation on the testes. So if this approach could be an option in terms of physiological increase in gonadotropins, this is not so good, I think, in the stimulatory approach. And as also the European Academy of Andrology, for example, reporting the guidelines, the evidence is in the literature is not so strong to give a real suggestion in favor of this approach.
So, Daniele, now we want something from your daily clinical practice, because the question is from a lot of the audience here. So, 3 ideas here. Which FSH dose do you use? Do you use on alternate days? Do you monitor serum FSH? These 3 questions, please.
Yeah, for what concerns the treatment, we use 150 units every other day, because this is the approach allowed by the national rule in Italy. I think that this is not the good option, but this is what we have to do from a bureaucratic point of view. There is no reason why we have to use an alternate days approach rather than every day, I think, but this is what we do.
Sorry, I was just wondering, because you showed us very nicely in the meta-analysis that actually the response to 250 is significantly less than response to 300. So why do you, I know that it's your regulatory, but you were the ones who actually were able to get this into the, let's say.
Indeed, in clinical practice, we are actually change our approach. So we start with 150 units, and then after 4 months, since we can prescribe for 4 months the treatment. Then, if the treatment is not efficient in terms of sperm change, so semen analysis change improvement, we increase the dosages and go to 300 units every other day.
Daniele, I was thinking because you say okay, semen concentration change, but we also have the biological variation in semen concentration, and as the change seems to be quite modest, how do you know that this came out of the FSH stimulation and not just of the biological variation that we all have?
Yeah, I thought about the sperm concentration because this is what we have as a parameter to monitor the efficacy. But I think, and we think that this is not the real and the proper examination, because from a biological point of view, the action of FSH is not only on the number, so stimulating the spermatogonia and so on, but this is not the good, but we have this, and so we have to think about what we have. And from a clinical point of view, we don't monitor FSH serum levels during the treatment as a standard approach. Sometimes we try to evaluate what happened in FSH serum levels, and using the standard dose, so 150 units every other day, we see that the FSH increased, but not so much. For example, if the starting point is 3 units per liter of FSH in the serum, or 4, the result is 8, 9, not so high. And so this is what we see in clinical practice, at least.
Thank you.
So Daniele, let me just, before we move to session number 2, there are some questions related to FSH thresholds, actually, to recommend treatment, because in Italy you have the threshold of 8 international units per liter. I mean, below 8 is actually what you are allowed to use FSH therapy, which is in the label of, gonadotropin. But if you have, let's say, a patient with FSH above 8, does it mean the patient will not respond? I mean, even if the patient has a potential polymorphism?
Yeah, I think that we have this limit, the limit of the bureaucracy, and we have this limit of 8 units per liter. But yeah, I think that probably we have to consider also the pharmacogenetic at the baseline before starting. But as already shared by Manuela, there are no use in clinical practice of pharmacogenetics and so of polymorphism analysis, but probably this should be introduced in the near future because FSH of 9 does not mean that for sure the patient does not respond to FSH, but this is what we have so far.
Thank you very much. I just want to add one quick thing in terms of the, the selective estrogen receptor modulators. In the urology community, it's very common to use 50 milligrams per day. And we need to be very careful because, for example, if I have a patient in group 2, in which the testosterone levels are normal, the testosterone levels in about 25% of patients can go beyond the ceiling level. And we need to monitor it closely because otherwise going above certain thresholds, if it's too high, could also have a detrimental effect in the pituitary, inhibiting FSH and LH secretion. So this is another caveat that we need to kind of think when using, these tablets. Now it's back to you, Peter.
Thank you very much. Thank you very much. So now it's my pleasure to present the next session. And here, what we try to do is to get a more practical approach, including cases and patients. And the first speaker I'm going to introduce is Lynn Antonio, and she's a medical specialist in endocrinology and diabetes. She works as an endocrinologist and andrologist in Leuven, but she's also an assistant professor at the Department of Chronic Disease and Metabolism of the Faculty of Medicine in Leuven. Her areas of expertise include andrology, reproductive endocrinology, and male infertility. So please, you're welcome, Dean.
Thank you. I'm just waiting for the slides. Okay, good afternoon. I will presenting a case for the Aphrodite group 1. So the man with hypogonadotropic hypogonadism. These are my disclosures. So the case I brought with me today is a 34-year-old man. We know him we follow him in our pituitary clinic because of congenital hypopituitarism. He was diagnosed around age 9 because of short stature. An MRI at that time showed a hypoplastic pituitary gland. He started treatment with hydrocortisone, thyroxine, and growth hormone, and he also received pubertal induction with testosterone that started around age 15. His treatment for his pituitary insufficiency is going fine. He's taking his medication very well. He's doing good. And then, he comes to our consultation 1 year and he says, well, I want to start a family. He's currently still on testosterone injections. He uses Cystanon, which is the most frequently used in Belgium because of financial reasons, every 2 weeks. It's a combination of testosterone esters, along with his other pituitary medication, growth hormone, thyroxine, and hydrocortisone. So we discussed with him and his wife what to do now to induce spermatogenesis in his case, and we switch him to ACG treatment, 1500 units subcutaneously 3 times a week. And after 4 months of treatment, we have a normal testosterone level, normal SHBG, normal free testosterone level. And we decide to add recombinant FSH to the treatments. This is also because of reimbursement criteria in Belgium. And so now we have a patient that is using ACG injections combined with FSH injections. What happens next? What we also did was a genetic panel testing of 30 genes because it's a congenital problem, but we did not detect any genetic cause of his hypopituitarism. There are many genes that can be associated with that. We use a panel that includes 30 genes. Most of them can be seen on the figure here. But in his case, we did not detect any genetic cause for his pituitary insufficiency. So we continue treatment with FSH and ACG. His hormone levels are still okay. Its testosterone increased to 1200 nanograms per deciliter or 42 nanomole per liter. But his semen analysis still shows azoospermia, although we have been treating him with gonadotropin injections for several months. We decided to reduce his HCG to 2 times a week to adjust the testosterone levels and discuss with him and his wife the further approach. And with that, he just 4 months later, his testosterone was okay, but the semen sample still showed azoospermia. Okay, yeah. So we discussed it with him and his wife what to do, and they decide to continue medical treatment. We continue the injections, and after about 20 months of treatment, there appears some immotile sperm in the ejaculate. We measure also inhibin B, which is in the normal range, and we discuss what they would prefer: continue medical treatment or progress to microTZ. And at that point, they decide to still continue medical treatment because after all these months, there were some immotile sperm in ejaculate, and they decide, well, we want to try to conceive naturally, and we want to still wait. We discussed the pros and cons intensively with the couple, and he continues medical treatment with ACG and FSH injections. Although he continues his treatment very well, he's very good at giving his injections. Semen analysis does not change. There are some immotile sperm cells in the ejaculate, some slowly progressing, but very few. Very bad semen quality at that point. And Isinibin B levels remain in the normal range around 180 to 200. So we discuss again, would you like to continue medical treatment or would you like to progress to microTZ? And eventually they progressed to microTZ, but after almost 3 years of medical treatments. Luckily, the microTZ was very successful. We could cryopreserve 19 straws. The biopsy showed hypospermatogenesis, and his wife was pregnant after the first embryo transfer and ICSI treatment, and they gave birth to a healthy baby actually this week. So in this case, with a patient with congenital hypopituitarism, we treated him with intensive gonadotropin therapy for a very long time, but in the end we still needed to progress to microTZ and ICSI to get to a pregnancy. Sorry, yeah. So to give you some background to the case I just presented, we'll have a look at some specific aspects of Aphrodite group 1. So this group consists of men with hypogonadotropic hypogonadism, which can be either congenital or acquired. And the main causes for these are mainly pituitary diseases and with combined other hormonal problems, but also congenital or isolated hypogonadotropic hypogonadism, where the other pituitary hormones are produced normally. These are rare conditions, 1 to 2% in a population of men that we see, but it's really important to provide proper counseling and specific treatments when men with these diseases want to start a family and want to have children. So to stimulate spermatogenesis in men, we have several different treatment regimens that we can use. There are several treatment regimens available. The most frequently used are either ACG in monotherapy or a combination of ACG with FSH. And there are also some data supporting sequential gonadotropin treatments, so starting with FSH as a pre-treatment, which is then followed by ACG treatment. In general, treatment with gonadotropins in men with hypogonadotropic hypogonadism starts with ACG injections. There are several treatment regimens that can be used. The examples are shown here on the slide. The doses of ACG that are available can be different from country to country, but for some men, ACG alone is not sufficient to induce spermatogenesis and to stimulate it's sufficient to stimulate the testosterone production in the Leydig cells, but not enough to induce spermatogenesis. And then usually after 3 to 6 months of ACG treatment in monotherapy, when there is no sperm in the ejaculate, we add FSH to further support spermatogenesis. Now, what can we expect from this gonadotropin treatment in men with hypogonadotropic hypogonadism? Here you can see data from 100 men that have been treated with ACG followed by FSH treatments. And you can see that spermatogenesis could be achieved in 70 to 95% of men, but that sperm concentrations can remain low in many of these men. So a lot of these men will still need will not reach sperm concentrations that are sufficient for natural conception and will still need assisted reproductive techniques. Another important point to highlight in men with hypogonadotropic hypogonadism and also evident from the case that I presented is that it can take several months to induce spermatogenesis in these men. And it's important to counsel the men and the couples about this. And personally, in my clinic, I counsel the young men I follow with pituitary diseases or with isolated hypogonadotropic hypogonadism about this timeline, that it can take several months to stimulate spermatogenesis, so they are prepared for the intensive treatment and the time it will take for them to induce spermatogenesis with gonadotropin treatments. This is another study that shows how much time it takes to induce spermatogenesis. This is in 81 men with hypogonadotropic hypogonadism who are treated with gonadotropins. The regimens that they used in the study are a bit, they used ACG in monotherapy or a combination of ACG and FSH. And in the middle panel, you can see the number of men and the percentage of men is on the right-hand side. And also, this publication highlights that it takes several months, sometimes even up to 18 to 24 months to induce spermatogenesis in men with hypogonadotropic hypogonadism. So patients should know about this, but also we as treating physicians should remain hopeful and supportive and continue treatment with gonadotropins in this specific group of men with hypo-hypo. Also, if there's no sperm in the ejaculate after 6 to 9 months. And then finally, to end, I would like to have a look at this small study. I know it's a small, two small groups that are compared to each other, but here they selected men with congenital hypogonadotropic hypogonadism. So important to realize is that these men have not gone through normal pubertal development, with gonadotropin stimulating the testis during puberty and inducing spermatogenesis normally during puberty. So the authors here started treatment with FSH alone as a sort of pre-treatment regimen to optimize fertility outcomes in men with congenital hypogonadotropic hypogonadism and very low testicular volumes when they started their treatment. So half of the group was treated with FSH in monotherapy for 4 months, and then followed by pulsatile GnRH therapy, and the other group was just treated with a combination of GnRH therapy and FS alone. Both groups had an increase in testicular volume and also normal testosterone levels, but the men that were pre-treated with FSH had higher inhibin B levels. And also all 7 men that received FSH pre-treatment developed sperm in the ejaculate, versus 4 of 6 men in the GnRH only group, and all men in the FSH pre-treated group showed higher maximal sperm counts. So it's a very small study, but it's, I think, gives a lot of questions and a lot of opportunities, I think, also in this specific group of men with congenital hypo-hypo that have not gone through normal pubertal development in the testis. So to conclude from my case and the data, in men with hypogonadotropic hypogonadism, gonadotropins are the only approved therapy, but there are many different treatment regimens. From previous speakers, we know that we are still looking for optimal treatment regimens to make our choice. You can use either ACG alone or a combination of ACG and FSH. In men with congenital or prepubertal hypo-hypo, FSH pre-treatment could be an option and could induce better outcome. You need to treat at least 6 months, but often treatment regimens are even longer. So in men with hypo-hypo, it can take up to 18 to 24 months to see sperm in the ejaculates when you start after starting gonadotropin therapy. Thank you for your attention.
Thank you very much, Lynn, for this very challenging case. Thanks a lot. Everyone, please stay with us because the questions and answers will be at the end of the session. Now I would like to invite Daniele Santi to present his case study slides.
Maybe in the meantime, we could just ask a question while waiting.
Yes, we can, ask Lynn to answer. There's several questions for her.
Lynn,
Sure.
Because Lynn, I have an answer. I have a question for you because this couple obviously was very, very patient, 3 years, and hopefully, I'm sure she was not of advanced maternal age. And
No.
I saw that obviously you tried to press them, or at least suggest a microtease after 20 months, because. And now you say microtease. Do you think you could just? This is just hypothetical. Do you think one could just have done a standard teaser?
It's possible. We usually take also the testicular volume into account when counseling for microtease or teasy. And in men with congenital hypo-hypo, they often they start with very low testicular volume. It can increase when you give gonadotropin therapy, but in those men we discuss pros and cons of micro-TZ-TZ, but based on the testicular volume, it's micro-TZ is an option. Yes.
Thank you. Get your point. Yeah.
So, Lynn, there are questions here related to the treatment protocol. For instance, I mean, these are congenital cases. They are the most difficult case. And also, this patient was on testosterone therapy. And this notion that we need to induce puberty using testosterone in this patient, I think perhaps needs to be revisited.
Yes, that's also still one of the points of discussion in andrology, I think, is how to induce puberty in these men. At this point, I think most pediatricians still use testosterone to induce puberty. But that, I think gonadotropins are also an option from the start. But I think there are no good data, or especially no comparative data, to say, well, one or the other is better. I think the important point here is when you see someone with congenital hypogonadotropic hypogonadism or hypogonadism that started before puberty, that you should counsel them properly as andrologists or reproductive gynecologists, reproductive urologists, that it will take a long time for the gonadotropin therapy to induce spermatogenesis.
So thank you very much. Perhaps one last question related to the, micro-TZ and also the fact that you had some sperm in the ejaculate, but still you prefer to retrieve sperm from the testicle. Would you consider, ICSI cycle with ejaculated sperm in this case to start with, or you prefer to
Well, most of the semen analyses showed immotile sperm. So because of that reason, we didn't do an ICSI cycle with the ejaculated material. And because we also knew that inhibin B was in the normal range, we suggested to do micro-TZ and then ICSI.
Okay.
So thank you very much.
Daniele, are you ready, or have you still got problems? You're muted.
No, I think it works.
Okay.
Okay. I changed the room, but yeah.
So the floor is yours, Daniele.
Thank you. They activate the slides. Okay. Okay. So here is about the group 2 and 3 of Aphrodite criteria. And so these are the two groups. So the group 2 is men with altered semen analysis, normal hormone levels, both FSH and testosterone. And 3 are normal FSH, but reduced testosterone. These are two groups that up to now are considered in the same larger definition of idiopathic infertility. Because up to now, we consider these men without a reason of their infertility. And so I just want to show that probably we have evidences that these groups are different. So I would like to start with the study that I showed you before about the real-world analysis about the application of FSH in clinical practice. So these are the men treated with FSH and that obtain a pregnancy in 1 every 4 days. But looking at this data, we tried to describe which is the difference, which is the response in terms of sperm concentration after FSH stimulation, but considering the starting point. And so considering the baseline level of semen analysis parameter. In this analysis, we tried try to describe and define which is this response. Here in the figure, you could see in the x-axis, the baseline sperm concentration, and the y-axis, the increase, the change better of sperm concentration after FSH stimulation. And is clear also from a first sight that there is a higher increase when the lower baseline sperm concentration was detected. And this is what we observed in clinical practice. But we, moreover, divided the patient according to the pregnancy achievement. And so in green, you could see men that are partner of a couple that reach a pregnancy. And in blue, men that are partner of couples that did not achieve a pregnancy. And the line tried to design the trend and this response. And you could see that the two lines are different for what concern lower baseline sperm concentration. And there is a sort of a threshold that here corresponds to 7.3 million on ml of sperm concentration. After this threshold, the two lines are overlapping, suggesting that the response to our stimulation, that is the stimulation of 150 units every other day, so the treatment that we do in hypo-hypo, so with a replacement approach, is efficient in a subgroup of these men, but not in the second subgroup. So we can consider the first group, so the group of men with worst semen analysis at baseline, as patients that better respond to this replacement approach, and so they are more similar to hypo-hypo, and a second subgroup that we can consider as a real idiopathic infertility because they did not respond to this approach of replacement therapy. And moreover, this have been shown at the beginning, but I think it's very important to stress these cases, is our result about the case control study. So we evaluated men with idiopathic infertility at baseline, so the characteristic detected at baseline, both hormonal and the semen analysis, and we compared these with men that performed analysis just for screening and not for fertility purpose. And as shown, that there is a significant differences in distribution of testosterone serum levels, and you could see that the distribution of total testosterone levels is shift on the left for men with idiopathic infertility. And in this group, there is the more than 20% of men that show reduced level of testosterone. In this setting, we use the threshold of 3.5 nanogram on ml of the total testosterone to define normal testosterone serum levels. We know that a clear threshold of testosterone is not available, but we can consider that testosterone below than 2.1 is clearly deficient, whereas higher than 3.5 is clearly normal. And so in this gray zone, we can consider that we have a subgroup of men with idiopathic infertility that could enter in this group 3 of the Aphrodite criteria. Thank you.
Thank you very much. So it's my pleasure now to actually introduce you, Sandro, to give your case and background information.
Thank you, Peter. So, okay, I will discuss Aphrodite, predominantly group 4, but you'll see that this patient has some overlapping with group 3. And now I'm more interested to discuss non-obstructive azoospermia, which is also part of the Aphrodite groups. So this is a case we treated in our center, a patient of 46-year-old with a 34-year-old nulliparous female partner. the primary infertility for about 2 years. This is the second marriage of this guy. No children in the first marriage. He's overall healthy with a BMI of 26.7, but has a past medical history of aortic valve insufficiency and a surgical history of aortic valve mechanic valve replacement. So he was on oral anticoagulant plus aspirin. This is a known case of idiopathic non-obstructive azoospermia. He had a normal genetic analysis, and he had a past surgical history of bilateral testicular sperm extraction done approximately 10 years ago during his previous marriage. And the findings were like this: no sperm found on the left side, and 2 abnormal sperm found on the right side, but they were considered unsuitable for ICSI. In the center they did the treatment. It was not in our center at that time. And histopathology obtained during that procedure showed pure Sertoli cell only bilateral. During the the workup, we found that his physical examination, he had small testes, about 8 cc, symmetric but soft, no varicocele, vas deferences were palpable bilaterally. We could not identify any epididymal abnormality, and he had normal virialization. Labs, he had a low total testosterone levels of 295 nanograms per deciliter, also low free testosterone calculated. High FSH was 41.7, and LH was 14.6, and the other hormones were normal, except 17-OHP that we also use as, kind of measure for understanding intratesticular testosterone. Would be like a proxy of intratesticular testosterone as suggested by some researchers. It was a bit low. And in the imaging studies, he had, confirmed the low testicular size, no microlithiasis, no nodules, minimal bilateral varicocele. So basically, this is the case presentation. But one important thing is that before, he also had, hormonal results from his previous operation before that. And as you can see here in the note, the FSH levels were 11.7, and he had the testosterone levels of about 337 nanograms per deciliter 10 years ago. This was before the testicular sperm extraction. So if you consider now the FSH thresholds of 12 that several, people use as the upper normal limit, this is the limit we use in our center, he had, what we consider FSH levels is still within the normal range. So at that point, he was like group 3 because he had low testosterone levels. We consider the threshold as 350 nanograms per deciliter. And again, FSH as 12. So he was group 3. And now he's clearly a group 4. We assume that it happened because a lot of tissue was taken during the previous testicular sperm extraction, and he became severely hypogonadal. So this is basically the classification. He's here in group 4, and before we could, suggest that he was in group 3. Well, because he had some sperm in the ejaculate, according to the history, although the histopathology showed Sertoli cell only, we offered him our treatment protocol for patients with non-obstructive azoospermia and biochemical hypogonadism. It starts with recombinant HCG. We give approximately 2,000 to 3,000 international units twice a week subcutaneously. It's self-administration. The patient does that at home. We adjust the recombinant HCG dose, and this is off-label, important to say, off-label indication for, treating biochemical hypogonadism and preparing the patient for, sperm retrieval. So we adjust the dose to achieve testosterone levels in the blood above 350, but not higher than 900 nanograms per deciliter, which will be around 31 nanomoles per liter. So the lower threshold, 350 or 12 nanomoles per liter, higher, approximately 800 to 900, which is about 28 to 31 nanomoles per liter. We add FSH, recombinant FSH, again off-label, 150 up to 2 to 5 international units twice or three times a week. If during the HCG treatment, FSH levels drop to around 1.5 or below. And we also consider giving aromatase inhibitor. If during the treatment, testosterone goes up, estradiol levels also goes up because of the aromatization. And if the ratio is below 10, to use the 10 as the threshold, you need to transform testosterone. You need to use the units nanograms per deciliter for testosterone and estradiol picograms per ml. Otherwise, this number 10 will never work. So basically, this is the treatment protocol. We give this treatment minimum 6 months, most often 6 months, but minimum 3 months, which is, let's say, 1 spermatogenic cycle. And we follow up these patients monthly with FSH, LH, total testosterone, free testosterone, 17-OHP, estradiol levels. And after 3 months treatment, we start also checking the semen analysis. So this is basically the protocol that we use for our patients. Just for you now to see what happened with this patient. So this is the baseline hormonal results, very high FSH, LH, estradiol, testosterone. And then we started with our stimulation. We started with recombinant HCG, about 3,000 units twice a week, because the testicles were very small, FSH very high. So we said, okay, let's start a bit higher. It means that using the recombinant, we use the pen device. It's about 12 clicks, again, off-label twice a week. And 3 months later, when we checked the hormonal results, we found that the FSH and LH levels were in the lower, let's say, normal limits, but the testosterone levels were too high, above this, the ceiling that we have in our protocol, which will be 900, 800 to 900. As you can see, free testosterone very high, an increase in estradiol levels, but when we make the ratio, it was below 10. You can make the ratio total testosterone to estradiol. Here is below 10. It's actually above 10. And you will see that 17-OHP high. So the patient responded well, but obviously too much. He remained azoospermic. 3 months later, we adjusted the medication. We reduced the dose of recombinant HCG to about 2,000 international units twice a week, which means about 8 clicks using the pen device. And then again, we checked 6 months later. The patient remained azoospermic, but here you can see that FSH levels kind of increased a bit. LH levels remained low as expected, because every time we give HCG, we are expecting that FSH levels are fully suppressed. And here you see the testosterone levels in the upper normal limits, also the free testosterone, nice, but an increase in the estradiol levels. Now the ratio is below 10. You see nice numbers for the 17-OHP. Due to the fact that we had, let's say, testosterone to estradiol ratios below 10 in our hands, we add aromatase inhibitor. We added low dose, in this case, an anastrozole. This is the preference in our center, 1 milligram twice a week. And then 1 month later, we checked again, and we see that 7 months treatment in preparation for, sperm retrieval. And this patient had FSH levels of 12. Every time we give an estrozole or any other aromatase inhibitors like letrozole, the FSH levels tends to increase. So you see the final testosterone levels were about 800, and estradiol levels reduced a bit. So the ratio was below 10. And then we actually proceeded for the microdissection testicular sperm extraction, which is our approach to collect sperm in this patient. Here you can see the operating view that we do in the center. We have the operating theater just kind of next door to the IVF lab. And we are lucky to have 2 IVF labs in which we can do the routine cases in one lab and the microtestic cases in the other lab. Here you can see what we found using, the magnification. The seminiferous tubules were predominantly hyalinized, as you can see here. But you can see here a very nice area of enlarged seminiferous tubules. And we found few areas like that in these patients. We usually measure the diameter of the seminiferous tubules. This is over 250 micrometers, which is a good sign that we will find some sort of germ cells inside, hopefully sperm. And in this case, we could actually find mature motile sperm retrieved, which was after a failed testicular sperm extraction before. Okay, so in this case, what we did was the patient was prepared simultaneously. We got 9 oocytes, in which 8 were metaphase 2. The fertilization using fresh testicular sperm in this case was 75%. And we got 5 blastocysts biopsied and cryopreserved. Here you can see the images of the blastocysts we got, 4 of them high quality and 1 not so good. The PGT-A results indicated that we had 2 euploid embryos for this couple, and the frozen embryo transfer is still to be scheduled. The patient is living abroad, so we are waiting for them to come and have the embryo transfer. Okay, so also important in this case, we had 8 specimens cryopreserved. Actually, we did 2 ways. Usually we try to do the cryopreservation like using conventional freezing, but when we have few sperm vitrification, in this case, we did both. We had 4 vials frozen in conventional freezing and 4 using the cell sleeper method, which is our vitrification protocol. And now, brief discussion about this case. I would like to touch on these 5 points briefly. The prevalence of non-obstructive vasospasm in Aphrodite groups, role of hormonal therapy, sperm retrieval techniques, what we can do in the lab, and what we can do in terms of the ovarian stimulation to maximize outcomes. In our center, which is a referral center for male infertility in Brazil, South America, we get a lot of zoospermic patients. As you can see, about 18% of the patients we see are zoospermic, mostly patients with non-obstructive vasospasm, like a spermatogenic failure this is the case we are discussing now. Non-obstructive vasospasm, spermatogenic failure, we are not talking about Aphrodite group 1 here. Patients with low, FSH, LH, testosterone. We are talking about patients with intrinsic testicular deficiency that could be caused by congenital issues, could be acquired, or could be idiopathic. But the point is that patients with non-obstructive vasospasm, they typically have high FSH levels, low testosterone levels, but there is also overlapping with other phenotypes in terms of the hormones. They can have normal FSH levels, and they can have normal testosterone levels, compensated still. And these patients, they have, let's say, focal intratesticular sperm production in up to 60% of cases. So now we can have patients with non-obstructive vasospasm in Aphrodite group 2, 3, and 4 with different phenotypes. And we wanted to know the prevalence of these patients. This is a recent study published a few months ago in fertility and sterility reports. For these patients, we used our database, including over 700 patients with non-obstructive azoospermia, and using the FSH, the baseline FSH cut point of 12 and testosterone cut point of 350, all these patients were not treated with any sort of hormonal stimulation, we could see a very interesting distribution of patients. In 10% of cases, approximately, we had patients fitting in Aphrodite group 2, non-obstructive azoospermic patients, all of them. Group 2, remember, they have normal FSH levels and normal testosterone levels. We had about 40% of patients in group 3. FSH levels within the normal range and low testosterone levels. And then a bit over 50% of patients in group 4. Group 4, they had high FSH levels, most of them with low testosterone levels, clustering here, as you can see, and a few patients with normal testosterone levels. This is how the patients distributed. And what is very interesting, we had the frequency of patients with hypogonadism in this population was very high, around 80%. So Manuela presented before around 30% in the overall population of idiopathic infertility, but you see that non-obstructive azoospermia, the situation is much worse. And why is it important? Well, because when we look at the sperm retrieval rates by microtesting in patient population, we found significantly lower sperm retrieval rates in patients who were hypogonadal, meaning that, perhaps there's a really role for, hormonal therapy in these patients. And actually, we have some data in the literature indicating that patients who have been treated with some sort of hormonal therapy had increased sperm retrieval rates compared to untreated patients, particularly if the FSH levels, the baseline FSH levels were below 12. So this is a systematic review and meta-analysis published in Human Reproduction Update in 2022. But the regimens were quite heterogeneous here, and the numbers actually in each study not very high, but providing actually, evidence from observational studies that there's a potential role for hormonal therapy. So what would be the rationale of using hormonal stimulation in patients with non-obstructive azoospermia? Well, we learned this in these previous sessions that spermatogenesis is regulated primarily by FSH and LH-driven testosterone. Hypogonadism is very common in patients with non-obstructive azoospermia, so these patients may lack adequate intratesticular testosterone levels that are essential for spermatogenesis that needs to act in combination with FSH stimulation. We are not measuring intratesticular testosterone levels, routinely, but we assume that these patients are having also low, because 95% of the testosterone that we measure in the blood comes from the testicle. The other important point is that stimulation of Sertoli and Leydig cells by the endogenous gonadotropes in these patients is paradoxically weak, because they have, because the baseline levels usually are either high or in the upper normal limits, the relative amplitude is low. And for the stimulation, we need to have, it's dependent on the amplitudes and also the pulses. And the other point is that we know by, several studies indicating that HCG therapy increases intratesticular testosterone levels. We have studies including measurement of intratesticular testosterone levels using, mass spectrometry. And that this increased circulating testosterone levels in most patients will reset the endogenous FSH levels to normal levels, potentially improving Sertoli cell function. So in our hands, patients with non-obstructive azoospermia, we perform sperm retrieval using microdissection testicular sperm extraction. This is a visual map of the procedure that we do. And we have also video that you can kind of go for the medeaacademy.com in the e-learning platform. In the previous webinars we had last year, the male infertility preceptorship, and you find a lot of things about that, including videos about the microdissection testicular sperm extraction, as we do at Androfer. So the reason we do these operations is because the procedure is more likely to result in successful sperm retrieval when we compare to conventional testicular sperm aspiration. And this data needs to be looked into studies directly comparing both procedures, not one or the other, but directly comparing. So it becomes very clear the superiority of microtesting. What we also do in these patients, for testicular sperm from azoospermic patients, we always do chemical activation to improve the fertilization rate. So before ICSI, we use pentoxifylline, regardless of sperm motility. And after ICSI, we use calcium ionophore for oocyte activation. And we have previously shown the benefit of actually using these stimulation protocols for improving fertilization rate in patients with a male infertility, in particular, non-obstructive azoospermia. And to conclude, it's also very important when we have severe male factor infertility to think about the female partner. We need oocytes to be able to produce embryos. And if we go for the ART calculator, which is the predictive model we developed to estimate the number of metaphase 2 oocytes required for obtaining at least one euploid blastocyst for transfer, in the study in which originated the ART calculator, we found that female age and sperm source, ejaculated or testicular sperm, specifically when it comes from patients with non-obstructive azoospermia, were relevant predictors for blastocyst euploidy. So as you can see in this graph, when we use testicular sperm from patients like the one I showed you, the probability of having, euploid blastocyst as a function of metaphase 2 oocytes decreased compared to ejaculated sperm. So in this case, when we apply the ART calculator that you can find in Medea Academy as well, you'll be able to kind of input the female age, the sperm source that was from the testicle. In this case, I use the success probability to be correct in my estimates of 80%. You can play a little bit with this percentage here. I adjusted the type of azoospermia for non-obstructive. And then, as you can see here, the calculator estimates that we will need 9 metaphase 2 oocytes to obtain at least one euploid blastocyst for transfer, the 95% confidence interval 7 to 11. And as you remember the case, we had 8 metaphase 2 oocytes, and we were lucky to have 2 euploid blastocysts, which, it's very well consistent with the estimations the calculator is providing. So as take-home messages from my case, here you can see the high prevalence of hypogonadism in patients with non-obstructive azoospermia. And these patients, they tend to have lower sperm retrieval rates versus eugonadal counterparts. The gonadotropin therapy may be considered to increase sperm retrieval rates in these patients. We can use HCG to boost intratesticular testosterone production, specifically in these hypogonadal patients. We can use FSH to kind of boost the FSH stimulation in patients with not so high FSH, of course, and this will be off-label indication. The other aspect that we need to, but we have limited evidence, and so far no randomized control trial. So also lack of studies comparing regimens and duration, so we need to advance our understanding with more data. in this field. And to conclude, the optimal sperm retrieval and ICSI outcomes in patients with non-obstructive azoospermia require careful planning and application of state-of-art, the clinical, surgical, and laboratory techniques. Thank you very much.
Thank you very much, Sandro. So let me see if I can get it running here, if I get my slides.
So now it's my pleasure to ask Peter to present his talk on the importance of addressing the male patient in the context of assisted reproductive technology. Please stay with us. We will have, after Peter's presentation, the questions and answer session. Addressing all the case presentations in this session and also Peter's talk. Please, Peter, the floor is yours.
Thank you very much, Sandro. So I was asked to give like an overview lecture on art before, but I would also say during and after infertility treatment. So we're just trying to get this running. So a few years ago, I wrote this book for lay people, and in Danish, semen is called sæd, because there was really a need for our males to have some information regarding their semen concentration. I called this book Super Semen. Now, what are the global infertility facts 2024? Well, we have approximately 186 million infertile people globally. It's 10% of all couples. 50% of infertility cases are caused by male factor, and we now have more than 8 million children born since '78. But the important thing is obviously 50% of children are conceived in art by ICSI. Now, these are merely Danish facts, but I would say they would apply to your country also in terms of, well, more or less the sperm counts, because 10% of the Danish birth cohort derives from ART, which is extremely high. And the reason for this is because we have a very good system with a high degree of reimbursement. 20% of Danish males have a low sperm count, and 25% of Danish males will never father a child. And I think what is important and what people never consider is that childless males actually feel more isolated and depressed than females in the same situation. Now, as regards infertility treatment, I would say that the male partner is still on the sideline, although he should be in the center court, taking into account that at least 50% of our treatments are caused by male infertility. But historically and culturally, fertility belongs to the female. A woman is considered responsible when she considers her inner organs, ovaries, womb, and vagina, and her functions as a wife and mother-to-be, as a very famous Danish gynecologist wrote more than 100 years ago. So this means that fatherhood belongs to the female, but then fatherhood belongs to the male, but then infertility belongs to the female. Now, if we look into the semen analysis 2024 and compare the first analysis described in 1916, there aren't a lot of differences because everything moves around concentration, motility, morphology, which actually does not say anything about fertility. And the eyes are still firmly fixed on the woman, and the male partner has been reduced to a semen blob, something very objective, and he doesn't regard his semen as something to protect. What is the current state of sperm concentration globally? Well, we saw this, or Manuela mentioned this significant decline, a more than 50% decline in semen concentration over the past 40 years. So we are now around 47 million in Western countries. And why is 47 million a problem? Well, because you need at least 40 million per mil to obtain a pregnancy within 1 year, according to a Lancet paper many years ago. So 47 million is extremely low. This is now in Western countries. So what about the China? Well, we see exactly the same trend here in the years from 2001 to 2015. So something is definitely going wrong. We saw this slide. We also learned that the yearly decline is accelerated globally from the first years until the years of the last 20 years. You can see the acceleration rate is nearly doubled from 1.16% per year decline to 2.60% decline per year. The problem is that we don't talk about our sperm count. I can guarantee you that these young gentlemen do definitely not talk about their sperm count or infertility problems while they're smoking and drinking after or during the party, as shown here. Okay, we have a problem. Let's see. Now, some years ago, we published this paper following 210 ICSI males and asking them in a questionnaire with a lot of questions how they felt about low semen count. And you can see that 28% reported a negative impact on their masculine self-image, 62% missed communication with the staff, and 63% felt that communication was primarily directed at the female partner, although the reason they were there was his problem. And again, 72% lacked information about male infertility. And this is why I wrote the book for lay people. How do we measure quality? We heard a lot about quantity today. And again, I would say, well, the only way we can measure quality is obviously DNA fragmentation testing. And I'd like to refer you to this review paper, which, as you can see, is co-authored by a lot of specialists within DNA fragmentation testing. So what is DNA fragmentation actually? What do we get from this? Well, we will get a little bit deeper into the soil when we start measuring DNA testing, because what we know is that the DNA is a double helix from two complementary strands which are held together by hydrogen bonds, just like railway sleepers in the DNA strand of the testes. So what happens if you have a break is obviously that you're going to have the same problem as with a railway sleeper break. You're going to have a derailment, so either no fertilization, low fertilization, poor development with fragmentation, and in some cases blastocysts which look excellent, but they are not going to give ongoing pregnancy, usually no pregnancy or just biochemical pregnancies. So when we talk about the DNA structure, DNA is damaged by oxidative stress, and DNA damage is completely normal because it occurs more than 100 times a day in a human cell. But somatic cells are capable of restoring the DNA damage, because if not, they will die or they would develop into cancer cells. Now, if we go into semen, the sperm cannot repair DNA damage. And this is why sperm DNA is so tightly packed to protect the sperm from damage. Another important issue is that DNA sperm damage cannot be visualized on the surface of the sperm. And these sperms with DNA damage are motile and can still fertilize the oocyte, either naturally or during ART, but very frequently will result either in implantation failures or early pregnancy losses. So you could say that the sperm cell is actually the canary in the coal mine, telling you something about the health of the male. So a kind of whistleblower. So a male with a very unhealthy lifestyle, for instance, would usually have a high DNA fragmentation index. Now, many years ago, 2007, we were actually the first to look into the impact of sperm DNA fragmentation in IVF patients. And as you can see, we had three groups: IUI, IVF, and ICSI. And we looked into, in those days, quite a high cutoff level of more than 30% Today, the cutoff level before we start getting problem is considered to be around 20%. Now, if we go for IUI, remember these were patients with completely normal semen. You can see that in those patients with a DFI above 30%, the delivery rate per started cycle was around 1% compared to 19% in patients with a lower DFI. As for IVF and ICSI, you can see it seems here as if the patients with high DFI would do considerably better performing ICSI as compared to a DFI. And obviously, this is caused by the incubation period in which the unhealthy sperms are going to produce a lot of ROS, which is going to damage the healthy sperms during the incubation period for standard IVF. Now, if you look in, the important thing from this one actually was that 20% of normal males had a DFI above 20%. So 1 in 5 of our IUI patients, and this would apply to your IUI patients also, had DFI breaks above 30%. So this is a very recent meta-analysis looking into the impact of DNA fragmentation and the outcome. And here for A is the compilation of IVF and ICSI. And what you see is if you get a risk ratio value less than 1 indicates a greater risk of a negative outcome. You see here that for implantation, it's significantly reduced with DNA fragmentation. Pregnancy rate also. For live birth rate, there's no significant difference, but there's a trend. Now, if we split the studies into IVF and ICSI, again, for IVF, negative impact on implantation, on pregnancy, and very close to negative impact on live birth rate also. Again, for ICSI, we don't see the same, although again, it's on the wrong side of 1, but it's not significant. So it seems as if what we were showing in those old days actually is corroborated by a lot of trials subsequently. Now, what can lifestyle do to DNA damage? Well, these are the thinning things that we should look into in our patients' daily life: alcohol, caffeine, diet, that is the fast food, overweight, sedentary life, tight pants, that's the heat, mobile in pocket and computer on the lab, electromagnetic radiation. Then obviously we have the environment also. All the endocrine disruptors of fertility, and all of us will usually encounter one or several of these environmental factors like pesticides, phthalates, bisphenol, parabens. The problem is that we usually have them as a toxic cocktail. So 1 and 1 is just not 2. 1 and 1 is going to become 4 because they potentiate their negative effect on fertility. Now, obviously, environmental changes are difficult to implement, but lifestyle changes, you can compare those to the speedboat. Whereas environmental changes, it's the super tanker. It's going to take many years, and hopefully our politicians are looking a lot into this. And I would say, don't ask what your country can do for you, ask what you can do for your country. And here, for a male, don't ask what your doctor can do for your semen, ask what you can do for your semen yourself. So if we go into what I call parenthood preparation, we would need to look into lifestyle change. And obviously the most important thing is nicotine and nicotine derivatives. So it's cigarettes, it's e-cigarettes, it's chewing tobacco, it's snuff, and it's cannabis. Ditch it, because in most cases, it's got a very negative impact on DNA fragmentation. So this is our suggestion in the unit in terms of a 3-month. And why 3 months? Well, you heard Manuela said it takes approximately 72 days to produce a sperm from the germ cell to a fully mature sperm. So 3 months fatherhood preparation in which you should quit smoking, you should reduce your alcohol, you should definitely reduce your caffeine, you should increase your exercise like 30 minutes daily of moderate intensity. And for the diet, less meat. We have too much processed meat at least in Denmark. So no more than 500 grams. We should have more fish, more vegetables, and weight loss if needed, mobile out of the pocket, and computer away from the lab. In 2022, we published this paper with Sandro, in which we were exploring the combined effect of lifestyle intervention and antioxidant therapy on sperm DNA fragmentation. And these guys who had to undergo a 3-month parenthood preparation were all partners in couples who had at least 2 failed IVF attempts. They all had a DFI above 15%, ranging from 16% all the way to 55%. They had to fill in a questionnaire with 68 lifestyle-related questions, and then we produced an individualized lifestyle change program, which the patients followed during a 3-month period. During the same period, they were also encouraged to take antioxidants in the sense of one multivitamin, 1 omega-3, that is 1 gram daily, and 1 Q10, 100 milligram daily. So we did DFI before and then DFI after this intervention. Now, what you can see is that 84% of participants actually achieved a decrease in DFI, and the mean decrease by this combination of lifestyle intervention and antioxidant therapy was 7.2%. And you could say, well, that's not a lot. Well, usually you would see the highest decrease in those with the poorest lifestyle. So a guy in these cases could have had like a DFI of 45, but after 3 months lifestyle intervention, he would be at 18%. Now, a very important thing is that we did not observe any differences in sperm parameters, in sperm concentration. I think this is very important to point out that lifestyle usually will have no impact on semen concentrations, and you need to advise your males about this before you start the lifestyle change program, because if not, they're going to be very disappointed. So the idea is to reduce the DNA fragmentation. Now, out of these patients, these 31 patients, 2 of these couples achieved a spontaneous pregnancy during the treatment. So another thing which has negative is obviously sexual abstinence. The longer the abstinence, the higher the DNA fragmentation rate. So we should definitely encourage our couples to have a very short sexual abstinence at home, but definitely also in our labs. So in our lab, we would always encourage our couples to have had sexual intercourse, or at least had the most of them would have an intercourse. Obviously, we would definitely encourage them to have had this at least the day before. And in many centers who do DNA fragmentation testing, if the test is going to be performed on a Monday, usually the recommendation would be to have sexual intercourse on Friday and Sunday, and then deliver a new semen sample on Monday. So sexual intercourse, or the DNA abstinence, plays a significant role. Another thing which is important is the effect, or negative effect, of antidepressants. You see all the names on the left-hand side, and please remember, a lot of our young males actually use antidepressants. What we know about those is that there is a significant negative impact, a huge rise in DNA fragmentation after just 4 weeks of SSRIs. So I think what we have to realize today is we shouldn't just look at the male as a semen sample. We have to look at the male as a patient. And a patient, you wouldn't just do a lot sample and nothing else. We have to investigate, as shown here in this slide by Sandro. We have to look into the lifestyle, the oral antioxidant intake, because some of our males will also take too many antioxidants. Have they got a varicocele? Have they got infections? Which type of ART are we going to perform? Are we going to do sperm selection techniques? etc., etc. So what about dropout rates in males undergoing gonadotropin treatment? Because we also treated a group of males from Aphrodite group 4, which was published. And what we can say is, in our hands, we don't have any male dropouts. And the reason for this is obviously a very close collaboration. We just have one nurse and one doctor handling these patients. And the male is highly motivated when it comes to his sperm. I usually say that the male is actually the most patient, much more patient than his spouse. So I think the infertile male 2024 is more than just a semen sample. ICSI does not solve all our problems. We have to look at a male in a holistic way. He's a patient. We have to look into all aspects, including his lifestyle, for him to be able to deliver not the highest quantity, but definitely the highest quality. Thank you very much.
Thank you very much, Peter, for the wonderful talk. It's kind of very inspiring to see a reproductive endocrinologist with the interest in infertility, supporting, as you do, male infertility treatment from the beginning. I mean, not only the intervention, but also the lifestyle and other aspects that are very important. So we have a few minutes left before we conclude our workshop today. And the session is open for questions. We have several questions in the chat. Would you like to lead this one, Peter?
No, I think we could do it. We could do it together, actually. I wanted. Let me just see. I have some questions I wanted to ask.
Let me just address this one, Peter, about the patients using anastrozole or letrozole, the complaint of erectile dysfunction by, it was a question posted here, and it's absolutely yes. Every time, I mean, you give anastrozole or letrozole, if you decrease the estradiol levels too much, I have several patients complaining of, low libido, erectile dysfunction. So I think we need to be careful in the dose of, in the case I presented, I was using small dose, only twice a week, of 1 milligram anastrozole to avoid, problems that patients actually can have by having very low estradiol levels. And when it's very low, the patient will complain of, erectile dysfunction.
Yeah, and Sandro, I wanted to ask you, because you came out with this interesting new data in which you could actually see that there would be no patients in both groups 4, 3, and 2
Absolutely.
of the Aphrodite. So does this mean that we have to reclassify Aphrodite, or what do you think?
No, I think it's nice to see that we have different phenotypes of patients with non-obstructive azoospermia. Like in group 2, if the patient has normal FSH and normal testosterone, most probably this patient in the testicle histopathology, it's a patient with maturation arrest. So these patients could be a very good candidate for FSH treatment alone. Patients in 3 could be a patient that we have, let's say, low testosterone levels and still FSH levels within the normal range, which means it's compensated. And then in that case, I would start with HCG, but be careful, because if we give HCG and the FSH reset is too dramatic, we might end up having very low FSH levels. So we need to combine, both HCG and FSH. And in group 4, we have limited data of beneficial effect. I showed the case that was in group 4. Still, we need more data. But in that case, there's no need to use, FSH, only HCG in that particular case, because FSH were still in the good range. But obviously, we could discuss if more would be better for that group of patients. This is something.
Yeah,
You
and
see
you
that
know,
we have patients in the 3 groups.
yeah, and you, as you know, you also co-authored the paper in which we were using your protocol in 8 NOAA patients belonging to group 4, most of them. And what we learned from this was that actually those who benefited from gonadotropin therapy were those with a late maturation arrest, whereas we didn't get any spermatogenesis in those with an early maturation arrest in NOAA.
Absolutely. It's difficult to kind of push the cells to reach, the mature sperm stage if they are very immature. In that case, in the paper you mentioned 8 patients. But what was very interesting in that case series of yours using this protocol, it was that in 2 patients, actually, we got some sperm in the ejaculate. Mm-hmm. Avoiding, sperm retrieval. And these patients, the 4 patients, 2 in which we got sperm in the ejaculate and 2 from the sperm retrieval, all of them got pregnant after treatment. So it was kind of a small case series, but showing the potential to explore in these protocols.
So Lien, maybe we could ask you, but maybe you already answered the question, but there's a question here. How do you choose between starting HCG monotherapy, HCG and FSH together, or pre-treatment with FSH only?
Well, that's an excellent question. Personally, in Belgium, we are limited by the reimbursement criteria, so we can only start FSH together with ACG. And a couple of years ago, we first had to start ACG before we could start FSH. I discussed the available data with the patients, and at this point, in men with hypogonadotrophic hypogonadism, I usually start ACG and FSH together. Because we are not able to do the FSH pre-treatment for financial reasons, reimbursement reasons. So I usually do it together at this moment.
Thank you.
But it varies from country to country, so it really depends on what you have available and how the reimbursement in your country is organized.
And maybe we could ask Daniela and Manuela. So, I mean, you are very positive to stimulation, and as Manuela says, now it's not a substitution. We really need to go high. And I saw that in the meta-analysis, doses of 700 units were used. I don't know whether this was daily or not. So you see this as a new, let's say, therapeutical area. You are muted, madam. Yeah.
What was the question actually? Because 750 units means 150 units every day. So
no, but I saw maybe this was Danielle who presented the meta-analysis on the effect of different dosing, and there was some very high dosings in the lower part, which actually really boosted spermatogenesis, whereas the lower dose did not have a significant effect. Is this true?
Yeah. In that meta-analysis, the higher dose is of 300 units every other day, so 150 every day. But looking in that meta-analysis, these results coming from one study that was 2 different trials, that is the study by Ding and collaborator. And so we have low evidences. So we have few studies in the literature to have a clear result on higher dosages.
And Daniele, how is male compliance? Because, injections every day for at least 3 to 6 months. I mean, our females also inject themselves, but it's considerably shorter time.
Yeah, in clinical practice, it is not a problem here. What we observed every day, they come here because they have a problem of infertility, and they do at least they tell us that they do the drug and the treatment. So I don't see so many problem about the injection.
And no, this is my experience also, and this is why I said the male is very, very patient, because this really affects his masculinity, and he wants to do something about this if he can.
Yes,
over to you.
We definitely need some more studies with higher dose, because the indications from the literature is that the more you do, the better you stimulate spermatogenesis, and most probably without any particular side effect, because you know, differently from women, you don't have to have problems or to think you could overstimulate. So I think we just have to try.
Over to you, Sandro.
Okay, we had many questions. I'd like to thank all of you for actually posting questions during this session. We were not able to answer all of them due to time limit. We will try to address them later with the speakers and then post the answers in the Aphrodite webpage. We are reaching the end of our session today. Thank you very much for all speakers actually to taking the time out and being here today. Also the participants from different countries, thanks a lot for taking the time out and staying with us for 3 hours. I would like just to finish my presentation